Good day, everyone. I'm Siang from Malaysia. Today, I would like to present the topic of triplane ankle fracture, a type of transitional ankle fracture in pediatric population. I have no conflict of interest with regard to this presentation. These are my contents of presentation. Introduction. Ankle injuries are common in children and rank second only to injuries to the hand and wrist in adolescents. Transitional ankle fractures are fractures that occur in transitional period of incomplete physis closure, which is common in age of 10 to 17, as the physis ossifies in a predictable order. It includes triplane ankle fracture, which is a softer Harris 4 ankle fracture, and Hillock fracture, which is a softer Harris 3 ankle fracture. I would like to share a case of 14-year-old boy presented to us with left ankle pain, swelling, and inability to bear weight post-mortem vehicle accident. These are the imaging. Plain X-ray shows fracture lines in the epiphysis on anterior-posterior AP view and posterior metaphysis on lateral view with distal fibular fracture. CT scan further confirmed the findings of triplane tibia fracture with distal fibular fracture, as shown in the imaging. He then underwent close reduction with screw fixation of left tibia, plating of the left fibula with application of fiberglass over the left columnar limb post-operatively as protection. So for the discussion, groove plate or biaxial fractures are common injuries in skeletally immature individuals, as the cartilaginous groove center is the weakest part of the bone, thus is more susceptible to injury. Triplane ankle fracture is a multiplanar injury involving the metaphysis, physis, and epiphysis. The term triplane actually refers to the different orientations of the fracture lines in the distal tibia, and it represents a frequent diagnostic challenge. It's often underappreciated with plain radiographs, as each view typically only reveals a single fracture line. Anterior-posterior, AP, lateral, and multi views of plain radiograph are essential in diagnosis. The epiphysis is fractured in the sagittal plane and is visible on the AP view. The posterior aspect of the metaphysis is fractured in the coronal plane and appreciated on the lateral view. The physis is fractured in the axial plane. The mortise view is the best way to appreciate articular displacement on plain radiograph. CT is vital for assessing the exact fracture pattern, degree of displacement, and articular step-off to guide surgical decision. Treatment is usually close reduction or surgical fixation, depending on the degree of fracture displacement and articular step-off. The prognosis is excellent, given the triplane ankle fracture is identified and appropriately treated. In conclusion, high index of suspicion is required to diagnose triplane ankle fracture, especially in those skeletally immature individuals aged between 10 to 17 with ankle trauma. Complications such as premature physeal arrest and angular deformity can be avoided if precise diagnosis and proper management are done. These are my references. Thank you.